All right, let's jump right in. Today we're tackling peritonsillar abscess. Now this isn't just your run-of-the-mill sore throat. We're going to go deep, tracing its journey from a nasty case of pharyngitis all the way to a serious, complex infection. We'll cover the diagnosis, the bugs involved, how to treat it, and what happens when things go really wrong. So here's our game plan. We'll start with what this thing, Quinsy, actually is. Then we'll get into the diagnostics, how we treat it in adults versus kids, the really scary complications you need to watch out for, and we'll wrap up with a little clinical challenge to put it all together.
Okay, first up, Quinsy. Let's break down what we're really talking about here, from its presentation to the underlying pathophysiology.
So what exactly is a peritonsillar abscess? You'll hear it called Quinsy, and it's way more than just a bad sore throat. We're talking about a collection of pus. A real walled-off infection that's set up shop in that space around the tonsil. And because it's walled off, it's not something that's just going to go away with simple antibiotics. It's this progression from a sore throat to a contained abscess that really changes the game and means we have to intervene, often surgically.
When a patient comes in, the clinical picture is usually pretty telling. The big clue, the one that should make your ears perk up, is that severe, one-sided sore throat. That's really different from your standard pharyngitis, where the pain is usually all over. Of course, you'll also see the usual suspects: fever, feeling generally awful, maybe a headache. And a little heads up for when you're dealing with kids, they might show up with some curveballs, like nausea or belly pain. So keep that on your radar.
All right, so we know what it looks like. Now, how do we confirm it and figure out what we're fighting? Let's get into the nitty-gritty of diagnostics and identifying the culprits behind the infection.
Okay, getting a sample.
This is where you have to be really careful. A throat swab might seem obvious, but, and this is a big but, if you see major swelling or have any suspicion of epiglottitis, you absolutely do not want to go poking around back there. You could trigger a complete airway shutdown. Seriously. In those cases, you pivot to blood cultures. The main goal with any culture we get is to make sure we can grow both the aerobic bugs and, crucially, the anaerobic ones.
Why did the bacterium break up with the fungus? Because there wasn't enough space in the petri dish for them to grow together. Yeah, I know, a little microbiology humor there, but it actually makes a perfect point. A peritonsillar abscess is a classic polymicrobial party. It's not one lone bug. It's a whole community of bacteria working together, creating this mess. And understanding that it's a mixed bag of bugs is absolutely critical for picking the right antibiotics.
And this chart really drives that point home. You see the usual suspects, right? Group A strep, Staph aureus, H flu, they're all in the mix. But look at that biggest slice. The real king of the castle here is often Fusobacterium necrophorum, an anaerobe. And that right there is the key takeaway. Its dominance is exactly why your initial empiric antibiotic choice has to have rock-solid anaerobic coverage, or you're just not going to win. Okay, so we know the enemy. Now, how do we fight it? Let's talk about treatment, specifically for adults. We'll look at the evidence-based regimens, starting with what you give intravenously. So if you've got a patient who's really sick and that abscess hasn't been drained yet, you have to hit it hard and fast with IV antibiotics. The go-to combo is benzyl penicillin to cover the strep, plus metronidazole to hammer those anaerobes we just talked about. Now, you got to be smart about it. If you're worried about Staph aureus, you'd swap in flucloxacillin, and for your really high-risk patients, think immunocompromised or someone with a head and neck cancer, you'd even add gentamicin to broaden that coverage even further. All right, once you've drained the abscess, you can start to de-escalate. The goal is to switch to an oral antibiotic. If you get culture results back, fantastic. You can tailor it perfectly. If not, the choice often depends on whether the patient has been on antibiotics recently. And you'll also notice here the specific recommendations for endocarditis prophylaxis. Super important to give that single dose an hour before you make that incision.
Now let's switch gears to our pediatric patients. And this is key. Treating kids is a whole different ballgame. It's not just about shrinking the dose, it's a completely different clinical approach.
So what are the big principles here? First, everything is dosed by weight and age. You have to use specialized pediatric formularies for this. No guessing. Second, you're going to have a much lower threshold to start IV antibiotics, especially if the child just can't keep anything down. Once they can, you switch them to oral meds. And it's interesting, a lot of what we do is actually guided by protocols for similar serious infections like acute epiglottitis.
Okay,
This is where things get really serious. If these abscesses aren't managed properly and quickly, the consequences can be absolutely devastating. We're talking life-threatening complications.
Just look at that number, 15 to 30%. That's the mortality rate for what is truly a worst-case scenario, descending necrotizing mediastinitis. This is what happens when the infection literally travels down the fascial planes of the neck and into the chest. It's an absolute catastrophe, and that mortality rate is just terrifying.
And it doesn't stop there. The infection can go systemic. We're talking about bacteria getting into the bloodstream, seeding infections all over the body, meningitis, septic arthritis, even brain abscesses. You can also get necrotizing infections in the soft tissues, or the body can spiral into that massive inflammatory response we call streptococcal toxic shock syndrome. The potential for things to go badly is significant.
This brings up a really important public health point. An invasive infection with group A strep, that's Streptococcus pyogenes, is a notifiable disease. That means if you identify it, you have to report it. Why? Because this isn't just about the one patient in front of you. It's about public health surveillance to catch and prevent larger outbreaks in the community.
All right, you've heard all the theory. Now let's put it into practice. We've got a few quick cases to test your thinking on some of the key points we've covered. Okay, case 1. You've got a 35-year-old guy, severe one-sided throat pain, fever, trismus, can't open his mouth wide. Classic story. So, what's the most likely bug causing all this trouble?
And the answer is C, Fusobacterium necrophorum. This just hammers home that point we made earlier. This anaerobe is so often the main driver of these abscesses, which is exactly why your empiric treatment has to cover it.
All right, next case. This time your patient is really sick and the abscess hasn't been drained. Given that this is a polymicrobial infection, which IV combo are you going to reach for to cover all your bases?
Yep, the answer is B, benzylpenicillin and metronidazole. It's that perfect 1-2 punch. The penicillin gets the strep, and the metronidazole takes care of that all-important anaerobic flora. You've got both critical components covered.
Last one. Let's talk worst-case scenarios again. Of all the things that can go wrong with an oropharyngeal abscess that isn't treated right, what's the critical high-mortality complication you absolutely have to be aware of? And of course, the answer is C, descending necrotizing mediastinitis. This is the one we truly fear. Its existence just highlights why we have to be so aggressive with diagnosis and management. Which, leaves us with a pretty big question to ponder in our own practice. How do we get better at spotting the patients who are at high risk for this before it happens? How can we intervene earlier to prevent these disasters from ever starting?